second talk, and this is how an intraoperative OCT helps you to do various kinds of keratoplasty. Of course, you can do it even without it. It just helps to fine tune your steps, and it allows you to see what you were actually not seeing earlier, and you would have to just imagine it. There are no financial or proprietary interests, and this OCT is a non-invasive diagnostic technique that renders an in vivo cross-sectional view of the optical tissue while you are operating. Now, we have experience with the microscope integrated OCT, which is integrated into the microscope itself, and the advantage is that it gives you real-time images, dynamic visualization, and in the same eyepiece where you're doing surgery, you can actually see the OCT picture. Of course, the flip side is that it is expensive and it may not be available at all centers. So there are various techniques of DALK, and the big bubble remains the gold standard. And you can do the big bubble. Could be a type 1 big bubble such as this, or it could be a type 2 big bubble which is there just above the Descemet's membrane, or type 1 big bubble is just above the Dua's layer. And when you're doing it, actually, this is a partial thickness trephination which is already done in a keratoconic cornea, and the air bubble is instilled in the supradescemet's membrane compartment. So in a real time, you can actually see this into your operating microscope eyepiece, that where the air has gone. So air has gone just above the Descemet's membrane, and as you give a nick in the overlying stromal layers, the air is egressing out and the Descemet's membrane is marching towards these stromal layers. And this is like a live show. So now again you inject viscoelastic to reinforce that compartment which had previously been created, and like a kangaroo's pouch, it drops down, and then the overlying stromal layers can be dissected, and the bare Descemet's membrane is staring at you here. You have done the surgery and you are still extraocular. So it helps you to see dynamically what is actually happening. Now this is the type 2 big bubble, where the big bubble is going from the periphery towards the center. It is marching towards the keratectomy site, and just once it comes here, it can stop short. Now another important thing is that when you're putting the needle, you know exactly at what level it is. So when you are about 80% depth, you know that you are in the correct direction. Now again, when you do AC paracentesis, you can see the dynamics of the Descemet's membrane, what is happening to it as you do the AC paracentesis, and as a nick is given here, it is going to move very fast. So by the way it moves, you come to know type 2 bubbles generally move very fast, as opposed to type 1 big bubble which march a little slowly forwards. So then the rest of the steps could be the same. Now it is very helpful to allow you a supradescemet's membrane dissection. So as you put viscoelastic into the supradescemet's membrane compartment, and as one sees it, one can see that you are coming very close to the area where you have to dissect. So you can keep reinforcing this supradescemet's membrane compartment with the help of the viscoelastic agent, so that it drops down and can continue your dissection without perforating the Descemet's membrane. Now, very useful in cases of healed hydrops, where actually you can see where the scar is. So when you do a manual lamellar dissection after doing a partial thickness trephination, in the area where the scar is present, by looking at the picture here, you can go a little anteriorly, so that you don't rip that scarred area open, and the Descemet's doesn't perforate in the area of the scar. And so you go a little anterior. It doesn't matter if a little bit of haze is left in the paracentral area, because ultimately the patient still has good vision, because that thing has moved out of the periphery. So I think I'll skip this, and we'll come to the post-op cases. Sometimes you have graft dehiscence such as this here after DALK, and again these cases can be tackled using the intraop OCT microscope, where you can actually see where the dehiscence is and where the Descemet's membrane is, without having to perforate the Descemet's membrane. Now, coming to DSAEK, in cases of hazy corneas, it allows you to see where your graft is. So here, you can't make out where the graft is, but when you look at here you know exactly where the graft is. It is floating somewhere in between, and as you put the air bubble, you can actually see the graft moving up. And now you would think you are done, but you're not done, because there's still some microscopic area which is there, and as you hydrate, this kind of moves again. So you can titrate your endpoint and can just instill air bubble over there, and then you know it is quite stuck and it is not going to move. This is what we had published on DSAEK IOCT guided DSAEK. Again, in DMEK, it is very useful. I think there is nothing about, not too much of use when you are preparing the DMEK graft, because the Descemet's membrane is stained, and so you can actually see what is happening to the roll, and it doesn't yield anything much, except that if you have taken a pseudophakic cornea, then you would know where the adhesions are present on the intraop OCT microscope. This is the S-shaped stamp which is being put, and subsequently this graft which is harvested. This is being done by, I call it Dr. Samar Basak's technique, because we've all learned DMEK from him. He came to RP Center for a workshop. So when you are now doing a DMEK in a case of Fuchs dystrophy, as you do Descemet membrane stripping, one can actually see, and if there are any remnants which are there, one can actually see on the posterior surface of the cornea. This is the Descemet's membrane roll which is being put, and this is an upside down roll. And this is the correct side up with the biceps curl upwards, and here the air bubble can now be instilled, and then you know that the correct side is up. Again, this is the post-op picture in the same case. This is a hazy cornea where stamping of the donor cornea has been done, but you can't see anything. Coupled with that, there are also Descemet membrane tags which you can't make out where they are. So after the graft is put inside, you can see the configuration here. It's a tight scroll. And then as the biceps curl upward configuration comes into being, then you can just tap and can instill air. Can't still see the S very clearly, but as the graft gets stuck to the back of the cornea and you put a little blob of viscoelastic, you can see that the correct orientation of the S is there. Again, there can be folds in a DMEK graft such as this. So you put air bubble, the fold is there which can be seen on this side. This part of it is folded. So from one side, inject fluid and put air bubble after that once the fold gets unfolded, which again can be seen here as you put the fluid, the fold gets unfolded and the graft then gets completely attached to the back of the cornea. Now, this is again useful in cases like DMEK for failed DSAEK post-penetrating keratoplasty. The DSAEK graft has got quite stuck to the iris, and again, this is an upside-down graft, so I wouldn't load it in this direction. I would load it the other way around, where the biceps curl is upwards, so that it goes biceps curl upwards inside, and that's it. So I would conclude this by saying that intraoperative OCT is a useful tool in armamentarium of keratoplasty surgeons. It helps to see the third dimension, and it helps to refine your surgery much better. Thank you very much for your attention.